So I'm gonna start this session, and I'm a medical oncologist, and what I thought would be important to do is to review the systemic therapy that has been available and that is available for mesothelioma. We have very distinguished researchers here that will talk after me that perhaps will address more of the newer things that are on the horizon. Because we have quite a mixed audience and there are patients in the audience, I'm going to talk a lot about the statistics and about clinical trials that have been done. And what I want people to keep in mind that a lot of these statistics don't apply to individual patients. They apply to groups of populations. But whoever is here certainly is an outlier, and please don't concentrate on the future and don't look at the numbers and get disappointed. So prior to 2003, there was no standardized therapy that was acceptable for mesothelioma. There was a meta-analysis of 119 trials that demonstrated that combination chemotherapy with cisplatin provided better response than cisplatin alone. In 2003, there were 2 international trials that were done that demonstrated that the combination chemotherapy with 2 anti-folate drugs, Pemetrexed and Reltitrexate, increased survival compared to single-agent cisplatin. Both trials showed a significant improvement in response rate and no deleterious impact on the quality of life. Pemetrexed is a fairly new drug, not so much new anymore, but the mechanism of action is that it interferes. It's an anti-folate that inhibits purine and pyrimidine synthesis, and it inhibits key enzymes that are important in the formation of purines and pyrimidines. The key enzyme, of course, is the thymidylate synthase, and it has the greatest effect on thymidylate synthase. However, it inhibits dihydrofolate reductase and a GARFT enzyme as well. Cisplatin, of course, is an old friend, and it binds to nuclear DNA and interferes with normal transcription when it intercalates itself between the DNA bases. So the trial that was done in 2003 was Pemetrexed and cisplatin versus cisplatin alone in patients with mesothelioma. This was a randomized trial. 456 patients were randomized. All of them had unresectable disease, and they were treated with cisplatin and Pemetrexed every 3 weeks versus cisplatin alone. And what that trial demonstrated that there was a longer overall survival and time to progression in patients that were treated with a combination. There was a statistically significant difference in response rate, time to progression, and overall survival. And this study established the combination of cisplatin and Pemetrexed on every 3 weeks as the new standard of care in 2003 and was a plenary presentation at ASCO. And similar results were achieved in a European trial that used Reltitrexate. So the current recommendation is to, of course, administer at least 4 courses of Pemetrexed and cisplatin. However, if delayed response is seen or if patients are responding well, we can go up to 6 courses. And when Pemetrexed is used, folic acid and B12 supplementation is required to decrease hematologic toxicity. So several questions have been raised about the use of Pemetrexed and the use of Carboplatin instead of cisplatin. So this question was asked and answered, and it was evaluated in the International Extended Access Program. This was a multi-center, non-randomized, open-label trial in chemotherapy-naive patients who received Pemetrexed and cisplatin and Pemetrexed and Carboplatin. And basically, the overall response rate, the time to progression, and the survival were equivalent. So even though cisplatin remains the standard of care, substituting carboplatin is certainly an acceptable choice. The next question was addressed is that can Pemetrexed be reused and can patients be retreated with Pemetrexed at progression? And again, another phase 2 trial was conducted in patients with progressive disease that were randomized to best supportive care or to single-agent Pemetrexed. And in fact, there was significant better response rate and longer time to progression in people that were retreated with Pemetrexed. And finally, this is a question that is borrowed from lung cancer. Is there a maintenance role for Pemetrexed, and can we use that? And there is an ongoing CLGB trial that is multicenter randomized trial that is looking at the question whether Pemetrexed maintenance is useful, and the goal is to determine whether maintenance therapy improves progression-free survival, and if that, overall survival. The trial is ongoing and due to close in 2005, where after 4 cycles of platinum and Pemetrexed, patients are randomized to receive Pemetrexed maintenance or best supportive care. So the question that everybody asks is that not everybody responds to our standard therapy, and are there any biomarkers that are available that we can use to predict clinical response, and can we identify the patients that will respond? So several biomarkers have been evaluated. There is a biomarker for Pemetrexed and biomarker for cisplatin. Thymidylate synthase, again, is the enzyme that is inhibited by Pemetrexed, and excision repair cross-complementation group 1, or ERCC1, is a DNA damage repair gene that removes cisplatin-induced DNA adducts and has been evaluated to look at cisplatin resistance. So there was an Italian retrospective study that was done looking at patients that have been previously treated with Pemetrexed and platinum or single-agent platinum, and levels of thymidylate synthase and ERCC1 were evaluated by both PCR and by immunohistochemistry. And if you look at these graphs, the gold line represents patients that had low thymidylate synthase levels, and blue line represents the patients with high thymidylate synthase levels. And what they were able to show that in patients that were treated with Pemetrexed and low thymidylate synthase protein levels, that was predictive of improved time to progression and longer overall survival. However, the thymidylate synthase values had no prognostic values in patients that were not treated with Pemetrexed. This is what was shown with ERCC1. Patients with a high ERCC1 level had a longer median survival than patients with lower ERCC1 levels, regardless of chemotherapy regimen that was employed. And there was no correlation in mesothelioma between ERCC1 levels and response to cisplatin or carboplatin, as has been showed in some other cancers. So other chemotherapy agents, in addition to Pemetrexed, the other agent that has been used is gemcitabine. Gemcitabine is a nucleic analog of deoxycytabine, in which 2 fluorine atoms have been inserted into deoxyribose ring. Gemcitabine competes for the incorporation into DNA, thereby inhibiting DNA synthesis. And prior to introduction of Pemetrexed, gemcitabine and cisplatin have been used as the first treatment in mesothelioma, with response rates ranging between 12 to 48%. As we have heard about in the previous talks, there is the patients with mesothelioma have significantly elevated levels of the vascular endothelial growth factors. And in fact, these levels are much higher than in other solid malignancies like colon cancer or lung cancer. So a phase 2 trial of anti-VEGF antibody bevacizumab has been evaluated when it was added to cisplatin and gemcitabine. And this was used as a first-line therapy. This was a phase 2 trial that the results of which were awaited anxiously, and patients were randomized to receive gemcitabine, cisplatin, and bevacizumab on every 3-week basis for 6 cycles. And the other group received gemcitabine, cisplatin, and placebo on every 3-week basis. The patients were treated for 6 cycles, and if no disease progression was noted, they were used the maintenance therapy with bevacizumab on every 21-day basis was used as opposed to placebo. And unfortunately, the results were quite disappointing. There was no difference in progression-free survival or in overall survival with the addition of bevacizumab. However, what was quite interesting is that there was a difference in overall survival if patients were stratified by baseline VEGF level. And patients with higher baseline VEGF levels had much worse progression-free survival and overall survival. And what was also somewhat disappointing is that VEGF levels were not different between responders and non-responders. And so there was no difference with the addition of bevacizumab. However, at the beginning of the trial, Pemetrexed was still not available, and now there is information about the negative interaction between gemcitabine and bevacizumab. So the next logical trial that was done is the addition of bevacizumab to standard chemotherapy, which is Pemetrexed and cisplatin. And this is a MAPS trial, which is a multicenter randomized phase 3 trial where patients are randomized and then treated with Pemetrexed and cisplatin with or without bevacizumab for 6 cycles. And then if there is no progressive disease, they're given bevacizumab on every 21 days. The preliminary results were presented at the IMIG meeting in Boston this year. This is a French trial where 280 patients have been enrolled so far. The goal is to recruit 445 patients. And there is an absolute difference in survival that is seen at this early analysis. So we're very excited for the results of this trial. The end of the accrual is expected in September of 2013. And biomarker analysis of tissue specimens is ongoing. So unfortunately, again, there is no approved or accepted second-line treatment for mesothelioma that has demonstrated a survival advantage. Many agents, just like many chemotherapy agents, have been investigated in the past. Now many new or biologic agents are being investigated with somewhat disappointing results. So there are anti-angiogenic agents that are in development. Tyrosine kinase inhibitors have also, such as of a different kind, have been looked at. Histone deacetylase inhibitors have also been evaluated in a large trial. Immunotherapy is on the horizon as well. I will not address the anti-mesothelin agents because they will be extensively discussed in the next talk. So the oldest anti-angiogenesis agent is thalidomide, and a lot of hope was given to thalidomide that could be used in maintenance therapy. So this was evaluated in a large phase 3 trial where patients that completed 4 cycles of standard chemotherapy were randomized to thalidomide at 200 milligrams a day versus placebo or supportive care. And unfortunately, there was no difference in time to progression or survival. And not only that, more adverse events were reported in this thalidomide group. Several other agents have been tried. Sorafenib is a potent inhibitor of the RAS, RAF, and MEK pathway, a pathway that is activated in multiple malignancies. It also targets VEGF receptor and c-KIT. A phase 2 trial was performed in patients in second-line chemotherapy. The response rate was pretty low, was only 66%. However, 54% of the patients had stable disease, and 2 different trials were done, and one of them had a longer time to progression of 5.1 months. However, the overall survival was similar in the 2 trials. Sunitinib has also been tried, another anti-angiogenic inhibitor of multiple tyrosine kinases, another second-line phase 2 study of intermittent sunitinib, 53 patients. Results were similar to the sorafenib trial, with median time to progression of 3.5 months and overall survival of 6.7 months. Cediranib is another anti-angiogenic tyrosine kinase. 2 different trials were done, again with fairly disappointing results, with even lower time to progression. And unfortunately, with this trial, there was significant grade 3 to 4 adverse events, such as pulmonary embolism, angioedema, and reversible posterior leukoencephalopathy. So this drug is no longer being looked at. Dasatinib, this trial I found very interesting, not only because it was done at the University of Minnesota, but also because it was a CLGB trial where patients were previously treated with chemotherapy. Dasatinib at 70 milligrams daily was used with a primary endpoint of progression-free survival. But what was very interesting about this trial is that they had an extensive biomarker analysis. They looked at the vascular endothelial growth factor, at the platelet-derived growth factor, and at the colony-stimulating factor, or CSF1. And in this trial, what they were able to show is that survival was markedly longer in the patients with lower pretreatment CSF level, and in patients whose CSF level decreased during the therapy. So currently, there is an antibody that is available to the CSF1, and from anecdotal experience from colleagues, patients have had durable responses from this CSF antibody in stable disease. The one trial that had a lot of people waiting for was the with histone deacetylase inhibitors. Just to remind you, to carry out gene expressions, the cell must control the coiling and uncoiling of the DNA. And this is accomplished by enzymes that are called acetylases. So when DNA is in a quiescent state, it is coiled, and it is in a tight conformation wrapped around the histone, a nuclear protein. It is uncoiled by an enzyme called acetyltransferase, and when DNA becomes uncoiled, it becomes the chromatin is more likely and more susceptible, so to speak, to transcription. So histone deacetylases play a role in the malignant transformation of mesothelioma, and high DAC inhibitors or drugs that inhibit histone deacetylases have been looked at and evaluated to see if they would play a role. So a very large trial called VANTAGE 014 was a multi-phase phase 3 trial. 660 patients that was previously treated with different therapies were randomized to receive vorinostat, a drug that is available in the treatment of lymphoma, versus observation alone. And they looked at primary progression outcomes was progression-free survival, and secondary outcome was overall survival. And unfortunately, again, the results of the study were disappointing. There was no difference in progression-free survival or overall survival. And even though numbers were statistically significant for progression-free survival, 6.3 weeks versus 6.1 weeks are not clinically significant values. So far, the agents that we have looked at are either cytotoxic chemotherapy agents or targeted therapy. The problem that we've had with mesothelioma is in order to have an active targeted therapy, you need to have a viable target, and we have had difficulties identifying that. So attention has been turned to immunotherapy as another approach. And there has been a very long-standing interest in harnessing or turning on the immune system to treat cancer. An immune response to, again, cancer, of course, is the body's natural mechanism of defense. And the clinical testing of immune-stimulating cytokines led to low frequency of responses, but the responses that were seen were durable responses. And interferons and interleukins are immune-stimulating cytokines that have activity in several cancers that are where immune system is active, such as melanoma and renal cell carcinoma. So just to remind you that dendritic cells are antigen-presenting cells, and they present, this is the tumor cell, so the antigen is presented to the dendritic cell. Dendritic cell processes the antigen and presents it to the T cell, and the T cells are the main effectors of the immune system's anti-tumor response. And this is what happens this is the interaction between the dendritic cell and the T cell. The T cell recognizes the antigen that is presented to it by the dendritic cell via its T cell receptor. It recognizes it in combination with self, or the major histocompatibility complex. So this is the first part of the immune response. The second part is this part right here. The T cells generate the immune response by binding of the CD28 antigen to the B7 antigen of the dendritic cell. And in this way, the immune system is activated, which results in increased production of these T cells that secrete interleukin-2, and also cytotoxic T cells that directly can destroy and target tumor cells. To avoid the overactivation of the immune system, there is an increased expression of CTLA-4, which is a transmembrane protein. The CTLA-4 is expressed about 48 hours after the immune system is activated. And what it does is that it competitively binds to the B7 cells, and it essentially outcompetes the CD28, so the immune response is turned down. And this is the dominant negative signaling that inhibits the immune response. So antibody to CTLA-4 has been developed, and that prevents the interaction with the B7 and removes the downregulation of the immune system. So essentially, it takes the break off from the blockade that is provided by the CTLA-4. And the blockade of this checkpoint provided the first evidence of improvement in overall survival in patients with metastatic melanoma. So CTLA-4 blockade with monoclonal antibodies, again, blocks the inhibitory signal, thereby sustaining the activation and proliferation of the active T cells. Two agents that are currently available, both of them are human monoclonal antibodies. Ipilimumab was approved by FDA in March of 2011 for the treatment of metastatic melanoma, and Tremelimumab is currently in clinical trials. Tremelimumab is a fully humanized anti-CTLA-4 monoclonal antibody with a half-life of about 20 days. It blocks the inhibitory signal. It enhances the T cell activation and proliferation, and by itself, it's felt to have enhanced anti-tumor activity. It has been used as a single agent in 9 different clinical trials in different tumors, And because there is a component of immune mediation that is felt to be coming from the asbestos and mesothelioma, this agent is upregulating the immune system, and it may have significant activity. So we are very excited about this agent. Some preliminary results from CTLA-4 have been presented at the 14th Lung Cancer Conference. They have had patients that have been heavily pretreated with advanced mesothelioma. The agent was found to be safe. 22 patients were treated. 2 of them achieved partial response, and 4 of them achieved stable disease. What was interesting about these is that almost all of these responses were quite durable. All of them were lasting more than 6 months, and 3 were lasting longer than 9 months. That is significantly better than anything that we have seen with chemotherapy. So we and some of our other colleagues that are here in the audience are opening a clinical trial that is a randomized double-blind study that is going to compare tremelimumab to placebo in second or third line treatment in patients with mesothelioma. The study is planning globally to enroll about 180 subjects, and people would be randomized 2-to-1 to get either tremelimumab or placebo. The primary objective is overall survival. Secondary objective is progression-free survival. We're certainly going to look at durable complete response, and this is where we're hoping we'll see a difference. We will also be looking at validating quality of life questionnaires, and we will also do a biomarker analysis, which is going to be key in their association with the tremelimumab treatment. The patients will be assessed with scans every 3 months, as well as questionnaires. So in conclusion, there have been some important changes in the management of mesothelioma. Chemotherapy regimens are available, but clearly this is not the answer. Much more needs to be done. We have briefly talked about during the previous session that mesothelioma is most likely in reality a sarcoma and should be treated as such. Certainly when there is sarcomatoid histology, this is a very different disease than epithelioid mesothelioma. The role of VEGF in first-line treatment is being investigated, and we're waiting the results from the large trial where it's used in combination with Cisplatin and Pemetrexed. What is more important is that the molecular and biological pathways are being worked out, and they really need to focus on further treatments. And role of immunotherapy and harnessing the immune system is very promising, and we're very excited about opening the tremelimumab trial here. And I would like to also acknowledge my colleagues in the UCLA mesothelioma program. Thank you.